Thank you very much for that introduction, and good afternoon to all of you. I'm delighted to be here today from the Department of Health in England, and I'm delighted to be joined by such an eminent panel of speakers from across the world. The subject of today's session is stemming the tide of non-communicable diseases, and this is a really important subject. Non-communicable diseases, particularly cancer, coronary heart disease, diabetes and respiratory disease, have increased in prevalence across the world, resulting in a considerable disease burden on our communities and on our countries. Non-communicable diseases are responsible for more than 60% of deaths worldwide, but they're also responsible for a great deal of non-fatal disease, which results not only in pain and suffering for our people, but also creates a huge challenge for healthcare systems across the whole world. As people live longer with chronic disease, this problem is getting progressively more severe. So what should be done? This is a problem which is exercising governments and international organizations across the world. And indeed, the WHO earlier this year produced an action plan for taking forward action on this issue. The aim of this session is to raise issues about the scale and nature of the issue from different perspectives, from different countries, and to discuss and share some of the approaches that are being taken or that are being proposed to address this issue. In particular, I hope we can discuss the role of governments and transnational agencies in combating non-communicable diseases, and I hope that many of you will contribute to this discussion. We're going to start the afternoon with 4 presentations from our expert panel. We're not going to take questions after each individual presentation. We'll wait till all 4 have had the chance to present. And I'm then going to ask the panel a few questions in order to begin the discussion. But for the last part of the sessions, I want to invite questions from the floor. So if you have a question for the panel that occurs to you as we go along, you may want to make a note of it as we go. So, to begin, I'd like to introduce our first expert speaker, Dr. Noor Hisham Abdullah, the Director General of the Ministry of Health in Malaysia. He's also an eminent surgeon, has been appointed to a number of senior leadership roles in surgery, including Head of the Department of Surgery in Putrajaya Hospital in Malaysia, Senior Vice President of the College of Surgeons of Malaysia, and President of the Asian Association of Endocrine Surgeons. Dr. Abdullah.
Thank you, David. Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. And first and foremost, I would like to, it's certainly an honor to be here and to talk about NCD. And NCD now is actually a global concern which extends beyond the health sector and impact on the entire socio-economic ecosystem. Having said that, it's perhaps a tsunami awaiting to happen. And if we do not address NCD today, all our economic gains will be lost in time. And we have to put NCD as a priority on our table. Otherwise, soon we'll be on the menu. So if you look into these slides that are transforming transforming the nation, Malaysia is actually moving towards from developing countries to become a developed nation by 2020. And it is very important for us to look into the health system, must also progress and transform to meet the needs of the developed nation. And here we must look back and understand where we were in the past, where we are now, and the challenges that we have in the near future for us to accommodate some of the challenges in the near future. And if you look into these slides, it's very clear that we only spend 4.6% of our GDP in healthcare. And over the years, you can see the infant mortality rate is decreasing, showing that what we have been doing is actually in the right course. And more recently, that we had our general election. And health was not an issue during a general election. In any countries going for election, health is certainly an issue. And last week, we were given, and this is health expenditure. So you can see the health expenditure is continuing to increase, but nonetheless, it's only about 4.6% of our GDP. And last week, we were given the award, 2013 United Nations Award on maternal health. And this is certainly an achievement that shows that we are in the right course of healthcare transformation. But the issue is whether our healthcare system is sustainable in the next 5 years, in the next 10 years. And if you look into this life expectancy, and from 1957 after independence, you can see that our life expectancy has increased. But with the compounding factors of NCD, as well as the aging population and escalating cost of healthcare in our country, certainly this actually put a strain into our healthcare system. And more so if it's a combination of the aging population and NCD, and we have shown that 50% of our population aged 60 and above have 2 comorbidities problems, and when they age 70 and above, they have 3 comorbidity problems. So this, again, will put a strain in the healthcare system, whether 4.6% of our GDP investment in healthcare is sustainable in the near future. And you look, here is the slide showing from the National Health Morbidity Survey, and you can see the prevalence of diabetes is increasing from 8.3% to 14.9%, and latest in 2011 in 20.8%. So prevalence of diabetes increased, prevalence of hypercholesterolemia is also increased, and obesity from 16.6% and to 29.4%. And obviously, this is a big challenge, a tsunami awaiting to happen. And again, all our economic gain will be lost if we do not take action. No action is indeed an action. In the near future, our healthcare may not be sustainable at all. And this is from the UN Secretary and emphasizing the role of the NCD in developing countries which are hidden, misunderstood, and unrecorded. And the rapid rise in the epidemic of NCD in developed and developing countries is certainly a big challenge to all of us here. And there must be a workable solution to prevent the existence of premature death from NCD and mitigate the negative impact on the development of each country. And we do have the National Strategic Plan for Non-Communicable Disease that is actually from 2010 to 2014. 7 strategies has been identified, and the prevention and the promotion is the most important if you look into the list of strategies that we have. And last year in the WHO 65 World Health Assembly, we have adopted a global target of a reduction of 25% in premature death from NCD by 2025. And we have identified 25 indicators and 9 target areas to be addressed in the near future. And we hope that we are able to execute some of the targets that have been set. And we need a multi-sectoral approach. Looking at NCD is not the responsibility of Ministry of Health alone, but working together across sectors, across other ministries, across other agencies to improve health and influence its social determinants. Forging a new collaboration and partnership are critical in making progress and addressing the NCD as an epidemic. And here is very important for us to move from curative to preventive, and the role of primary care. Family physician must be emphasized, and healthcare should be developed around the individual, families, and the communities, not too much on the hospital and providers. And here, government, communities, and NGOs must play a role, and in partnership, this is actually a multi-sectoral approach for us to tackle NCD in the near future. Here are the social determinants of the health. And we need to have a health-seeking behavior among our patients. And our behavior of the patient is influenced by environmental hazards, lack of education, inadequate food and nutrition, unemployment, poor hygiene, poor employment, poor housing, poverty, etc., and etc. So these are the things that we have to work in multi-sectoral to address the issue of NCD and focus on the individual patient towards a health-seeking behavior. And this is the model of operationalizing the multi-sectoral approach. The government needs to take the lead in making policies, and comes down to the consultation with a multi-sectoral approach and set up the policies and that we can execute is a win-win situation for both parties. It's a top-down and bottom-up approach, and then we have to look into the implementation, get the feedback. Again, there's a cycle going on. So with that, ladies and gentlemen, I thank you for your attention.
Thank you very much, Dr. Abdullah. And I think the issue of the importance of prevention in order to make our healthcare systems sustainable for the future is one that we'll return to later. Our second speaker is Dr. Omar Saleh, who is currently Emergency Preparedness and Humanitarian Action Coordinator for the WHO in Somalia. Dr. Saleh is a medical doctor initially who specialized in emergency surgery, but has more recently worked providing emergency preparedness and humanitarian and medical response in some of the most difficult circumstances, including war zones and natural disasters. Dr. Omar Saleh.
Good afternoon, ladies and gentlemen. Can you hear me? Can you hear me? Yeah. Good afternoon. Can I ask you please to stand up? Stretch a little bit. Yeah. Thank you very much, please. Thank you. Non-communicable disease was considered the black sheep for decades, actually. Then studies were done and made by several doctors and professors about the gravity and the importance of non-communicable disease. Started maybe from 1977. The World Health Assembly, for who doesn't know, this is the meeting where all the ministers of health from all the member state governments come every year in Geneva in May, and they declare or they agree on the strategy for the next year. 2012, they decided to adopt a global target of 25% reduction of the premature mortality of NCD. Premature mortality is the dying before the age of 60. We'll go forward. Why NCD? Why they picked NCD? Why they met and they decided to talk about NCD or to take an action against NCD. Even the World Economic Forum, we hear in the economy or the economic meeting, has decided that NCD is a barrier and threat against the development of the world. Poverty, as you all know, if you have a chronic, if anybody has a chronic disease, then he can't go to work. He takes leaves and early retirement. He's not productive. He's a burden to his family. Instead of being productive in the family, he's a burden in the family. And even they created a global movement against premature death and disability in the common preventable morbidity and mortality. The studies shows that NCDs cause half or more than half of the death before the age of 60, particularly in or commonly in the low-income and mid-income countries. Any of you have been to Africa? Anybody had been to Africa? Do you know the Big Five? What's the Big Five? What's the Big Five? Rhino, buffalo, lion, tiger, and elephant. Thank you. So those are the big five killers here. Heart disease, cancer disease, chronic lung disease, and respiratory disease. Some countries, they put liver disease, and other countries, they put diabetes mellitus. It depends. Now, this year, in May 2013, again, the Global Health Assembly, they made an action plan against this NCD. Now, non-communicable disease are causing most of the deaths and actually anticipated to be even to increase more in 2030. So they had to take an action. The plan was based on comprehensive package of primary prevention, treatment, and surveillance. Surveillance to get to know the gravity of the situation, the number of the situation. As you know, if you are in a low-income country or the third, what you can call the third world countries, it's difficult to find data. So you have to have data first to understand the gravity of the situation. Then WHO member state adapted that. So actually, I assume that each Minister of Health from all your countries agreed on that one. The goal, the basic goal, that NCD has to decrease 2% every year. This is a female girl from Africa, and she has cancer. Usually when you say Africa, when you say Southeast Asia, the first thing comes is cholera outbreak, measles, polio. Nobody thinks that, yeah, they get cancer also. The thing is, most of the money, the donors, is going towards the communicable disease. For these ones, very, very little. Awareness is very little. The awareness of the community is very little. The treatment is little. The early detection is even not there. Now they agreed on this strategy. The plan has to be health effective. So what we're going to do, what are the activities, has to be health effective and cost effective. And low cost of implementation, political and financial feasibility, back to the black sheep. Doesn't sell. Non-communicable disease doesn't sell, doesn't get you re-elected. So it has to be feasible, politically feasible. There are so many lobbies acting against what you want to do. There are priority actions like the leadership, the prevention, the treatment, and the priority intervention activities. What are the activities? So what are the big killers? They found if you can control tobacco, if you can control the salt intake and healthy diet, and exercise, as you said, as you did now, you see movement and stretching, and decrease hazardous alcohol intake. Some of them, they added also the essential drugs and technology is available. As I was mentioning to my colleagues today in the morning, in some countries there is no insulin. No insulin. Primary diabetes will die. Secondary diabetes, uncontrolled, will die. Ampoule of insulin. Simple. And this is the global monitoring framework of the NCDs. These are the indicators. Premature mortality has to decrease 25%. The salt intake 30% to be decreased. Further reading. WHO actually published a very, very nice book. It's online, and this is accessible. Has all the information about the non-CD and the gravity of the situation and actually the action. Shukran jazilan. Thank you so much.
Thank you, Dr. Omar, Saleh, and I think that sets the scene very well. And I think both the first two presentations give some idea of the urgency of the problem and the need to take action quickly. We're going to change tack a little bit now. Our next speaker is Dr. Smisha Agarwal, who is the Chief Executive Officer of Global Health Bridge, an organization dedicated to using mobile tools to improve healthcare around the world. And she's a faculty member at the Bloomberg School of Public Health at Johns Hopkins. Her work is focused on using mobile technology to strengthen health systems in developing countries, and she's recently been working with WHO Technical Advisory Group on mobile health interventions for maternal and child health. Dr. Smisha Agarwal.
Good afternoon, everyone. So I'm going to be talking about a new approach to thinking about non-communicable diseases, but first to set context a little bit. And I think the first two presentations have already done that quite well, but clearly non-communicable diseases have become an emerging challenge of this generation, with about 60% of global burden of disease attributable to non-communicable diseases. Interestingly, even in low and middle income countries where infectious disease was more of a challenge, now we see a trend, an epidemiological shift towards non-communicable diseases contributing to close to 50%. And I think projections by 2030 estimate that close to 70% of the deaths in low and middle income countries would be attributable to non-communicable diseases. So in 2011 at the World Health Forum, Margaret Chen spoke about non-communicable diseases as a slow motion catastrophe. And I think Dr. Hisham just referred to it as a tsunami. And the significant challenge of chronic disease compared to what we were dealing with infectious disease is the significant burden of management, long-term management. So in low and middle income countries, in resource-constrained environment, being a diagnosis of hypertension or diabetes means an early death, to put it briefly. However, there are some similarities which as far as we're dealing with infectious diseases are concerned, there are some common themes and some common challenges that we can learn from. So in terms of patient-level care, simple things that everyone here has mentioned this afternoon is patient awareness, empowerment, education. At provider level, training for provider competency, as well as accountability. And health systems level, thinking about supply chain management or stockouts or data management, monitoring. You don't measure it, you don't know it. So, so now, over the last decade, we've been presented with a tremendous opportunity with the number of mobile subscriptions set to exceed the total population of the world at 7 billion. I think it's just to take a moment to think about it. These are some of the populations with no access to water, no access to electricity. But you will find that each household has a mobile phone. And it gives us a tremendous opportunity to look at healthcare, especially at the bottom of the pyramid, in a unique way. Also great opportunities for public-private partnerships because most of the telecom competencies lie with the private sector, but the healthcare outreach at the bottom of the pyramid is with the public sector. So we're going to look quickly at some illustrative examples of how we've been using mobile technologies at the various levels that I mentioned, patient, provider, and health systems. So this is Proxil, and there's a simple barcode that you can punch into a cell phone, and it tells you if the drugs are counterfeit, which in several parts of, this is being used in Ghana, and we know in several parts of Africa, counterfeit drugs are a big challenge. Going one step behind that is SMS for Life, where, you know, often I'm sure that that some of you may know that in low-income countries, a patient might go to a clinic only to find that there may be no doctors or there may be no drugs to treat them. And so this is looking at an SMS-based system to prevent stockouts of drugs and in primary care facilities in partnership with the Ministry of Health in Tanzania. mHealth is mobile technologies for health, and for tuberculosis and HIV, again, a simple SMS-based reminder or IVR, interactive voice-based reminder, we now have a vastly growing body of evidence that shows that this simple intervention can significantly improve patient compliance to treatment. And I think similar applications can be made to diabetes or hypertension. O-scan for oral lesions in areas which have shortages of health workers. The lower cadre workers can be trained to remotely diagnose using the imaging capabilities of a cell phone to diagnose precancerous lesions. mHealth for smoking, this is actually a study in London School of Hygiene Tropical Medicine, which has shown that motivational text messaging to long-term smokers can actually support smoking cessation measures. There are comparable interventions done in the United States as well, and in several parts of India as well. So I've spoken about a wide variety of the use of mHealth applications from patient education, awareness, empowerment, which is all in the realm of prevention, to provider level of diagnostic, treatment, remote diagnostic, as well as disease tracking, surveillance systems, data management, monitoring of provider compliance to treatment strategies. I think the applications are tremendous, even the focus areas within the realm of non-communicable diseases. I think it's a vastly growing world, and I'm definitely very excited about it. So thank you.
Thank you very much. And now we'll move to our last speaker, Dr. Yousef Shahin, who is the Chief of Disease Prevention and Control at United Nations Relief and Works Agency for Palestinian Refugees in the Near East. Dr. Shahin is responsible for the development, monitoring and evaluation of UNRWA's program for disease prevention and control for both communicable and non-communicable diseases. He also spent a while with the WHO East Mediterranean region as a technical advisor on NCDs in 2011. Dr. Shahin.
Good afternoon, everybody. I will bring you back to the prevention of non-communicable diseases again, actually. If we look at this slide, we can realize how the burden of non-communicable disease is moving onward. In 1990, you can see that around only 44% of communicable diseases were responsible for the death, while in 2020, it will reduce to 20%. On the opposite side, the non-communicable disease will be the leading cause of morbidity and mortality, and it will be causing around 60% of deaths in 2020. This, of course, if we will stay going in the same way that we are doing it now. The injuries also will be increased because injuries themselves are also accountable for the morbidity and mortality among population. The global situation also affect the middle income countries, and we are from Mediterranean Eastern region. We are now counting around 55% of deaths are responsible for non-communicable diseases, and over 60% of disease burden are related to these diseases. As my colleagues already mentioned before, these are mainly diabetes, hypertension, cardiovascular disease, respiratory, and cancer. Unfortunately, 6 countries from our Arab Islamic world are in the 10 leading countries in the world in diabetes. 5 of them are from the Gulf. Kuwait, Lebanon, Qatar, Saudi Arabia, and Bahrain, and United Arab Emirates are among the 10 leading countries in diabetes as a prevalence. The other issue that we are still having problem with the risk factors. The risk factors are increasing by the time. This is why the WHO has put a plan in order to combat non-communicable diseases and to reduce the burden of the effect of these diseases by 2020. Already Dr. Omar covered this plan, and I will not focus more on that. I will move to highlight some facts about the organization that I am coming from. I am supervising non-communicable disease program in United Nations Relief and Works Agency, which is known as UNRWA, which was established in 1949 by UN General Assembly resolution. UNRWA, for those who don't know, it's an organization that providing services to Palestine refugees for around 63 years, health, education, relief, and other services. You know that UNRWA has been providing these services free of charge, and the burden on UNRWA is increasing from time to time. This is why UNRWA has both plans for prevention of NCDs, and we adopt in our setting 3 main strategies, which mainly it's primary prevention, secondary prevention, and tertiary. We do some sort of screening program for our population, and those who are at risk, we also screen them for diabetes and hypertension and breast cancer for women, of course. Also, we had some practical solutions and interventions in our setting, because we really believe that plans, strategies, policies are not effective if they are not implemented. This is why we had integrated in non-communicable disease into our primary health care and now into the family health team approach that we already started 2 years ago. Also, we had a very important issue in engaging community. Without community, we cannot succeed. Also, the other issue that we are doing is we are focusing on how to reduce the risk factors among young population. We are having now a lot of children that with high obesity rate and type 2 diabetes. Children are sitting behind the computers, they are playing with the PlayStations all the time, they don't exercise. This is really a very risky issue. Also, one important factor is the partnership with the private sector and the NGOs. We need also to be leaders by example. We would start by ourselves. Doctors, medical officers, health staff should do the healthy issues in order for the patients to follow them. And a very important issue that we are focusing is the interactive theater. We have used this interactive theater to address messages, healthy messages, how we can combat NCD among population. This is one of the examples you can see on the photo. Our Commissioner General, the head of the UNRWA, is cooking by himself, healthy cook, and showing people how we can healthy cook our food. The other slides showing the play presented to diabetic patients, how we can reduce the obesity, how we can address health messages in a humor way. This slide also shows how we invested in healthy canteens inside the schools. This is one of the photos. You can see the Dr. Margaret Chan, she's the Director General of WHO, and Dr. Ala Ilwan, he's the Regional Director of IMRO. They visited these healthy canteens in West Bank, in Palestine, and they were very, very, very impressed with the experience that we are doing. Thank you very much.
Thank you, Dr. Shahin, and thank you to all the presenters for those presentations, which have really set the scene. And I think the key messages coming out of those for me are that non-communicable diseases are a major problem for every country in the world, and we're all struggling to deal with this. And our approach to dealing with it must involve tackling prevention. We must have sustainable healthcare systems. We must have international cooperation, surveillance, and cooperation. And also, we've seen that technology has a role to play in all of those areas if we're going to tackle this problem. What I'd like to do now is just move on to a discussion amongst the panel about the issue of NCDs. And I'd like to start with Dr. Abdullah. You raised the issue of the importance of having a sustainable healthcare system, and you also raised the issue of the importance of prevention. Public health authorities around the world are often saying that too much money goes into the hospitals, into the secondary care sector, not enough into prevention. Do you think that's the case with non-communicable diseases, and do you think we have the balance right?
Certainly not. Actually, you look into our national health accounts, our expenditure for curative hospitals and clinics basically is more than 45%, and only in prevention less than 4%. So we have to actually focus on not the hospitals, but the preventive measures. And in terms of, we have seen that our data have shown that there's an increase pre-diabetes, hypertension, cancer cases and all that. That will be a big impact on the healthcare system. And if you continue to focus on the provider, basically it's a bottomless pit, and then a lot of investment actually put on the infrastructure as well as the technical expertise. But we need to have the preventive actions, and this is where we need primary care to play an important role, as well as family physicians to take a role, taking preventive measures to the community, to the family, and to the individual. We need to have a health-seeking behavior of the individual who knows what to eat and knows what to do to prevent of this the behavior, to prevent the NCDs in the near future. But what's more important is that the behavior is influenced by the environment, social determinants in the environment, and we need to control that as a multi-sectoral approach to tackle all the issues as we mentioned earlier.
Thank you very much. And Dr. Saleh, you mentioned prevention as well as being very important. Yeah. And we've seen economic analyses which tell us that we need to do this if our health systems are to remain sustainable. What do you think are the barriers to introducing more prevention, to have more effective prevention of NCDs?
It starts by leadership. NCDs is no longer just a technical issue, technical matter only among doctors. It has to come, now it's becoming a political thing. So the leadership has to start. The leaders has to identify the importance of NCD and have to start a national plan in each country to against or to prevent NCDs. Then that's the first thing. The second thing is the awareness, the community awareness. Education, donors. NCD is not from the way it's funded. It's seriously underfunded. It's not identified as, again, like cholera or polio or whatever. Then the international, as you was mentioning, international cooperation. It's not just one country alone. It has to be, all the countries has to come together. Donors, the international donors has to come together. And then there has to be monitoring, how to monitor, and surveillance. If you don't see it or you don't know it, you don't know the gravity of the situation. Surveillance has to be there. Information has to be shared. Experiences has to be shared. Lesson learned has to be shared.
Okay, that's great. Well, I'm moving on to Dr. Shahin first. We have this WHO action plan now this year, which outlines how we can address prevention, but also other measures which might improve the outlook for the management of non-communicable diseases. Do you think that's enough? Do we need to do more?
Yeah, actually the WHO plan put the guidelines and the elements that we have to follow. But these are theoretical, as my colleagues already mentioned. We need to be practical, implemented, and we need to implement these plans as easy as we can, because really community does not need any plans. They need implementable practical steps. One of the main components of the WHO plans, as Dr. Omar already mentioned, is the commitment of the leadership and the engagement. If we will have commitment from the management and leadership, for sure these plans would be implemented. The other issue that we have to focus on is the community involvement, participation of the community and the partnership with different sectors of the community. Because really this is not an issue of health anymore. NCDs are the problem of everybody. Of the economics, of the politics, of health people, of education, of everybody, because it is addressing all people, not only a special group. And as you can see now, there is a trend in increasing of risk factors among young population. Really, there is alarming figures regarding smoking. We have done, as WHO also did some studies, we have done what we call a global youth tobacco survey, and we realized that 35% of our students are beginning smoking at the age of 11. You can imagine that. And the obesity rate is very high now among the young population, and we are now seeing diabetes type 2 among this young population. So the action plan is very nice plan, but we really need to all to work together in order to implement the plan into action.
Okay, and do you think that a global action plan can really work, given the differences between countries, between the wealth of the countries and the infrastructure that they have?
Yeah, I think it can work. It can work, but it needs a lot of efforts. It needs a lot of partnerships. It needs joint work from all sectors. If this will be in place, for sure the plan will work. And we have some examples in some countries where they could implement the plan because of the commitment of the leadership and because of the joint efforts from different sectors in the country.
Okay, thank you. Dr. Agarwal, you highlighted some of the opportunities that technology offers for tackling some of these problems. And indeed, whenever we have a healthcare problem, we often really look to technology to provide solutions. How big a role do you think that research and development and new technology will play in tackling NCDs?
I think it's the future of where we are headed from now. Just to refer back to some of the points that Dr. Saleh and Hisham pointed out to in terms of the barriers to prevention, is the way communicable and non-communicable diseases are funded is not for prevention. So for example, a cataract program that I was working with needed, or an eye program that I was working with needed number of cataract surgeries as opposed to community prevention for early identification. That's a tangible source that can be measured at a point of care in a hospital. So I think one of the challenges is that we don't have the surveillance to measure wide-scale community-level prevention, success of community-level prevention. So, for example, mobile technologies can play a tremendous role in that. We've been looking at community health workers going, messaging from point of care at community level, and so creating a more active, live, minute-to-minute surveillance system. But scaling up of something like that takes tremendous government as well as international commitment. So these programs have mostly been pilots and small scale, but there's tremendous opportunity for the future.
Okay. There seems to be quite a lot of support on the panel for moving towards a more preventive approach. Are there any models that you can describe of a different kind of healthcare system where prevention has been applied in this way, which has shown benefits? I don't know who to address that to. Perhaps Dr. Saleh, would you like to comment?
Say again?
Thinking of alternative models of healthcare systems where prevention plays more of a role, do you know of any examples where a different approach has been tried so that prevention has been prioritized and has produced better outcomes?
Yeah. Actually, what we can say, inside the box and outside the box, thinking. So all this, our approaches so far, again, to tackle the NCDs are not that effective still. So the prevention, starting from the prevention, that's hopefully proved to be better. Let's remember, or in another way, why those people who doesn't do physical activities and eat unhealthy food and use tobacco haphazardly or hazardously and use alcohol hazardously, why they're doing that? What's the root that led them to do that? Is it environmental? Is it educational? Is it genetic? Is it stress? Is it their way to overcome stress? I would suggest that we have to put some effort to understand the root. This is one of the major causes of death, or now actually it's the major cause of death in life, in the world. And we should invest in researches and studies to understand the root of that behavior.
Okay, thank you very much. Well, thank you to all the panel members for that. What I'd like to do now is open up questions from the floor. So if you'd like to speak, you could make yourself known. Do we have microphone stands that people can make use of? Yes, sir. Would you like to ask the first question?
Assalamu alaikum and good afternoon. My name is Datuk and I'm from Bangladesh. I have no question, but I like to appreciate Miss Smisha Agarwal. I think one of the areas where we can actually gain, very quick outcome is the replication of some of our ideas. Creating awareness. The father is always saying his child that don't do this, don't do this. And if the mobile phone can be used to say that you should not do this, you should not do this. And the fund may come from CSR, corporate social responsibility. The cell phone company, they are having huge growth worldwide. And as she said that there is no food, sometimes no water, but there is a mobile phone. And I have seen in Africa also. So my proposal would be to find an initiative that can actually replicate one of the aspects, creating awareness using the mobile phone. Thank you very much.
Thank you. Dr. Agarwal, do you want to comment on that?
I think you might be aware that in Bangladesh there's currently a national level program called MAMA, which is USAID funded, and that's looking at basically providing mobile-based or text-based support to pregnant women through antenatal and postnatal period. And they don't have They don't have concrete data yet, but there's great expectation that it has significant improvements in health outcomes. So I definitely think that in Bangladesh and India, we mostly use mobile phones to get cricket updates, but we can transition to more purposeful ventures.
Okay, thank you.
Azad Khan from Bangladesh Diabetic Association. I will make 4 specific proposals, actually. Number 1, you see, we all agree that tobacco is harmful. So why not United Nations be persuaded to make tobacco growing illegal, like they have done for opium, you see. And why not this panel takes up that, you see. Next is, this is the meeting of the WIEF, and we have not used the strength of the imams in spreading prevention message, you see. Like every Friday, the Muslims go to the mosque and the imam gives a sermon, you see, and it can be. I have explored that in Bangladesh, and in Bangladesh, all the imams agreed that, because in Islam, there is a very strong message by our Prophet about good health care. Number 3 suggestion is mobile phone. It can be used also as a gateway to the approach to the healthcare that will reduce the cost. So that we are now experimenting with that. Number 3 is a very controversial issue, but I would say, you see, insulin is essential for life. And type 1 diabetes would die without insulin. And as Dr. Saleh was telling, that some countries insulin is not available. Why not propose that insulin is a human right issue? You see, like air, like oxygen, like water or food, insulin is a human right issue for type 1 diabetics. Finally, before I leave the microphone, I just want to comment about a slide where they show the percentage contributed to the mortality. And I think diabetes is shown inappropriately because nobody dies, hardly anybody dies due to diabetes. You see, if you think of that way, only ketotic or hyperosmolar coma would be direct cause. The diabetic die of heart disease or stroke. So that's the slide may be misleading. Thank you.
Okay, thank you very much. Quite a lot in there. I'll ask all of you to make a comment on any of those that you're interested in. So we start with you, Dr. Saleh.
Thank you so much for your comments. First of all, the United Nations to make tobacco growing illegal. Good luck with that. As we said, it has...
I'm sorry, sir, we can't hear you when you're not by the microphone. So if you just let Dr. Saleh respond, and if you want to come back, if you could go to the microphone, that would be helpful. Carry on, Dr. Saleh.
I can't hear you. So, yeah.
You see, I had the opportunity to work with Sir Richard Dole, and he was once telling me the amount of adverse fight that he had to be with the tobacco industry, you see. And let us be honest, you see, because this tobacco is not banned to grow, that's because of the harmful effect of the tobacco industry. We must be able to be fair and ethical, you see, and then it can be. Here I am also again raising an issue of the UN Day for Diabetes. Most of you would know that it was initiated by Bangladesh Diabetic Association, sponsored by Bangladesh government in the United Nations. And all the countries have signed that. And it implies that every country should take up national policy for prevention.
Actually, the one which proved to be most cost-effective approach was to increase the tax on tobacco. That was the only approach which was, studies showed that it is cost-effective. The second thing is using the imams. Yes, we do that, and actually it's a known approach. But when we use it with cautious. Whatever the message is, it's not just the message of activity or not to smoke or not to drink alcohol. Even in the vaccination, we use the imams. But again, that has to be very, very cautious because it's not always. Yeah, I leave the insulin as a human right. Many things has to be a human right. Access to health is a human right. And you wouldn't imagine in some certain areas, just access to health is almost impossible. Thank you.
Okay. Dr.
Yeah, I
Abdullah?
just had to respond to the questions with regards to increase the tax. When we increase the tax of tobacco, and there's a lot of increased smuggling into the country, illegal smuggling of tobacco, and we also play an important role. I think WHO has set a war against tobacco, and under the leadership of the WHO DG, Dr. Margaret Chan, and he's actually fighting with the tobacco company. But what's more important in the latest, for example, the TPPA deal that we have, so Malaysia wanted to carve out tobacco out of the TPPA deal in that area. So that is actually some of the initiatives that we have taken to combat tobacco in our country. Thank you.
Dr. Shahin?
Just to add on the message about how we can better deliver our messages to community, I agree that Sheikh Imam has a role to play on that. Also, this can be better accepted by the population, and we are practicing this in our setting, and there is a lot of healthy messages has been delivered through mosques and churches, and they will be very effective, and this is already in place. And regarding to the best buys that already WHO is promoting, as already my colleague said, that one of the methods to combat the high rate of smoking is increasing taxes. But really, we also need to enforce laws. Laws are not well enforced in many Arab countries and in the Middle Eastern region. And there is very, very nice public health laws preventing people from smoking in public places, transportation, but unfortunately, this is not the case when you go to these places. The issue of implementing the laws is very crucial.
Thank you.
Well, I'm in agreement with the rest of the panel, and I think the family planning program in Bangladesh has been, is very well renowned for imams playing a critical role in actually promoting that, to promote the health of women. So that's been widely used. As far as making something a human right, I think health was a human right many decades ago, but that didn't change access to healthcare for people. It changed a political commitment towards healthcare, but I think within our own countries, we really have to look at the practical steps that we can take in the absence of a structured system where policies are actually made actionable. What can we do in the absence of that structure as well?
Thank you. And can we move on to the next question now, sir?
Okay, thank you. I'm from Somalia. My name is Mohammed Omar. I'm very glad to be with you here. And also I'm very happy to hear Mr. Saleh, who is representing WHO for Somalia. Before I address my question, even though I have some comments, I would like again and again to thank the organization really who was behind this big important meeting, and also allow me to say thanks UK government who hosted us this beautiful country. I'm from Somalia. As you know, Somalia has different environment, and we know some disease related with the climate or with the environment. I want to ask Mr. Saleh, if you take an example, the malaria disease, mostly it has affected the people, those are living in the intravenous area between Juba River and Shabelle River. So we never got a sustainable development or health care project which is implementing W in that area, and they are suffering now more than hundreds and 100,000 Somalians from the beginning of Beledweyne up to Kismayo. And we know there is a lot of money goes from the donors to the international organizations, and at that time, they are collecting that money to help the vulnerable people. Those are, most of them, starving or dying in Africa. So as we are Somalians, we have today many refugees, many displaced people, some of them in the country, others outside of Somalia. All these problems we have, and also there is another big problem that we are having from some companies or some ships. Those are coming from the development countries. Those are putting radioactives in the Somali seashore. So these poison and dumping toxins affected the life of thousands and thousands, the lives of Somali families. Most of them are children, others are women. We are surprised when we are here in a humanitarian organization. Those never say a single word about that. Only what we are hearing from the world is Somalia there is a pirate, Somalia there is a terrorist. And those are looting our resources, killing, poisoning our seas. Nobody's saying anything about. And the lot of money that we are always hearing from the international community saying we spend Somalia, they have given for the corrupted government, and our government, they never have seen any money from the donors. They are all used by the international NGOs. Those are representing departments. Another time, and really, our people, they are not getting nothing about that. So, my brother, he's from Arab world. Thanks. Some countries like Emirat, they have crossed, and and some Red Cross, Emiratis, and also Qatar, and also we got Saudi Arabia, and also we got Sudan, and also others from European countries, but as a government is. But what about these international NGOs? Those are, most of them are,
so if you could,
you know, and those are really represented.
I'm sorry
yeah,
to
I'm
press
sorry,
you,
I'm not accusing them,
we
but
want
I want to say.
we want to get a lot more
Yeah,
questions
okay,
in if
just,
we can, please.
yeah,
So
just we want to know really where it is going, that money. An example, what is the reality on the ground which they has done up to now? The countries like Somalia, who has been affected them, everything, including disease and all the kinds that you are mentioning here. Thank you very much indeed.
Thank you. Would anyone like to comment on that, Dr. Saleh?
Mr. Muhammad, you're a member of the parliament, if I'm right. Am I right? Yes. Yes. First of all, your question is doesn't relate to the topic, but lucky enough, I'm actually a member also of the evidence-based aid. So your question is where the aid is going. You see, WHO is not a donor. WHO is the United Nations, yes, World Health Organization. So we support the government or the local authority. As far as we understand, we have a malaria program in Somalia, in Kismayo we have, in Beledweyne we have, in Baydawa, in all South Central. As I said, WHO is not a donor. So the action, the response is based on the availability of the funds. If there is funds, then there is inaction. If there is no funds, what we do is mainly the advocacy and awareness and addressing and actually even lobbying with the authorities just to bring more money. How the money is used by the government, that's something I cannot comment on. That's away behind or far away from my area of expertise. And I agree with you totally on the Somalia is only seen as the pirates and terrorists and whatever. Actually, Somalia has so many things which unfortunately are not addressed by the media. And thank you.
Thank you. Can we move to the next question, please?
Assalamu alaikum and very good afternoon. My name is Hazim Muhammad Nordin. I'm actually a student doing industrial PhD in looking at treatment alternatives for NCD, specifically using hydrotherapy. Now, my question is, there seems to be a lot of emphasis given on curative aspects of managing NCD. There's not much done on the preventive side, apart from education and stuff like that. One of the speakers mentioned just now that, you know, we need to find a solution that's really in line with how we behave. For example, the research I'm doing right now is actually going back to the basics, going back to the lifestyle of individual. You know, why are people smoking? Because their friends are smoking. Why are people, you know, taking alcohol, for example, or even drinking very heavily carbonated waters? Because that's the lifestyle. So my question to you, to the panel, has there been enough studies or has there been initiative taken to actually come up with solutions as far as lifestyle is concerned? Thank you.
Thank you. Dr. Shahin, do you want to take that one?
Surely, it's a very important issue that when we talk about theory, theory is nice, but practice is the most important and difficult issue. We need to implement the theory into practice. This is why we are searching for simple, practical solutions for population to accept. Recently, we started what we call diabetes campaigns in UNRWA, in our organization. We involved around 1,600 diabetic patients in these campaigns. It consists of health education, cooking shows, healthy cooking shows, and physical exercise, and counseling, psychosocial support. Believe me that this is very well accepted by the patients. Changing the attitude of a patient, of a person, is a very difficult issue. But when you start, you will find it's possible. When you lead by example, you will find it is possible. This is why when we gathered patients together with the health staff and they started doing the exercise together, when they started doing cooking shows together, healthy cooking shows together, they started doing the same activities together, they improved a lot. And since we started these campaigns, we are measuring the outcome indicators from 1 month to 1 month. And we have seen a lot of positive change in the attitude of population of these patients. And we have seen a lot of decreasing in body mass index, body weight, I mean, and also improving the control rate for blood sugar and blood pressure. Nothing is impossible, but we have to start, and we have all to cooperate together, because alone we cannot achieve. This is why we mostly emphasize on the importance of partnership with all, NGOs, private sector, UN organizations, government, everybody should all work together in order to achieve these results. Thank you.
Thank you. Perhaps I could ask a supplementary to that for anybody who wants to answer, and that's what should be the role of industry and the private sector in this? And many of the risk factors for the non-communicable diseases are the same, as smoking, diet, exercise, and so on. What about, for example, partnership with the food industry, with the tobacco industry? Do any of you have any views about how we could exploit that to improve the levels of non-communicable diseases? No?
Well, I just think that, unfortunately, the two rarely go in hand, especially when it comes to non-communicable diseases. Recently, as many of you might have heard, there was a huge outrage in New York City with Mayor Bloomberg putting a cap on the size of beverages, of non-alcoholic beverages, and there was a huge amount of industry lobbying against it. So I think that's definitely a very challenging area to deal with.
Okay. When I look into the question that you have posed, it's very important for us to look into the preventive measures and start early. And there's a proverb in Chinese saying that the first 3 years of life actually determines your lifespan to 80 years old. And the return on investment, especially the younger age group, and in terms of the habits, in terms of habits, bad habits and so forth, and education of preventive measures is much more effective if you start early in preschool. And here, Ministry of Health, for example, you work closely with the Ministry of Education to bring health education to the school level, the preschool and the primary school and secondary school, and emphasizing, and we have this program called the Young Doctors. So they played a role in terms of the influence to their colleagues in school, having a good practice in terms of avoiding all these effects of NCDs in the near future.
Thank you.
Actually, I believe that this is a very good idea. And there has to be a discussion, and there has to be talks between the people working on health and the political bodies and these industry companies. Because at a certain point, the CEO of this industry company is going to die from cancer or heart attack or whatever. Then he has to come in terms. But it will. I don't think that it is easily feasible, but it's a good step.
Okay, thank you. Right, can we have the next question, please?
Yes. Good afternoon. My name's Anthony Phillips, the MD of Welcome International. I think the discussion this afternoon has been very enlightening. It's not the kind of multifaceted strands. One of the things I just wanted to share, for example, I had a similar conversation with a health minister in the Caribbean, and he asked me that they have 2 strokes a day on the island and lots of issues around NCDs. And one of the things that we were discussing is that one of the questions to the panel, he asked me, well, what's happening in the workplaces in education? And I said that around the world, we've never come across in employers the competency around personal wellness management. And yet we believe that there are 4 life skills. You have to be able to read, write, use IT, and manage your personal wellness to actually survive in this life. But when we talk about education, we've done some studies in schools, for example, correlated using a psychometric instrument on lifestyles with teachers. And we found that health education doesn't work because the pupils don't believe that, the delivery person. Because what we found is that often in poorer schools, the people delivering it, their lifestyles are the opposite of what they're actually teaching. And there's an American expression, which I won't embarrass you, but it begins with bull and ends in with S-H-I-T. And that's where health education is going. So the question, but we have the validated instruments and psychometrics, but one of the biggest barriers is why don't we recognize that personal wellness management is a core capability or competence, first of all in the education systems and also in the workplace?
All right, who would like to comment on that? Yeah, Dr. Saleh?
Yeah,
no?
I'm fine with that.
I'm fine. Yeah.
I think we all agree.
Yeah, I agree with that, yeah.
We all agree, but the question is, well, if I can apply for any job, a teacher, a salesperson, I can apply even as a nurse, and nobody will ever ask me any questions about how do I manage my personal wellness, how do I stay well physically and mentally, how I'm going to manage on a daily basis, on a yearly, and for the next 10 years. And if you take Malaysia, you've just increased the retirement age, for example. And one of the issues that some employers asked us in Malaysia is, could we forecast what the impact was on the retirement age of people? That's what they want to do. Physically and mentally, the lifestyles, what's the implication on productivity? And with the MPC Productivity Council. But why don't we recognize it? Why don't we ask employers to say, as part of HRDF funding in Malaysia, to recognize personal wellness management as a core capability?
Well, I think that's an excellent comment.
We fully agree with that.
We fully agree with that, actually. There's no doubt about that. And,
thank you very much. Do we have any other? We have a question here. There's a microphone just behind you, sir, I think.
Jeremy Gurlis, forgive me, I'm not from within the medical sector at all. My question or observation might seem frivolous or flippant, even somewhat arrogant, but there probably hides a bigger truth. I've been at the conference here for 3 days, For breakfast, I've been offered Danish pastries and biscuits. At every meal, I've been offered 2 sugar-based desserts, only once fruit. Every one of you is sitting here under the banner of your strategic partner, the Coca-Cola Company. And more than 50% of the stalls out there, including some of your governments and organizations, are offering sweets on their stand. Can I ask each member of the panel to categorically state if they support this, if they're prepared to do anything about it? Because it is absolutely fine showing the charts and saying what you say, but here, on the ground, surely you are facing something that is very, very different. Thank you.
Thank you. Well, I mean, your point is absolutely well made that a culture change is required, and certainly in a lot of public sector organisations in this country, they are moving that way, you know, and fruit has replaced biscuits and whatever. But yes, there's a long, long way to go. I appreciate that. But you're right, the way we live our lives, the environment we live in predisposes us to get non-communicable diseases, and that's something that we have to address. Would anyone like to comment?
I agree with that. Yeah, actually, we have to start by ourselves because really the attitude of people is very difficult to change. A healthy diet is very, very important issue to prevent non-communicable diseases. I can talk in our setting. We now, when we organize any workshop, health-related workshop, we don't bring any junk food, we don't bring any sweets, we just offer the healthy food. We are not the organizer of this actually forum, but really, we cannot impose our ideas on others. But I fully agree that we should stick to healthy diet. We should have our food very well selected in order to prevent NCDs.
Okay, thank you. Yes.
Actually, it is highly appreciated, your approach regarding preventing non-communicable diseases. However, we should accept as well that there are some patients waiting for care in all over the world, in different countries, and they couldn't get it due to the lack of doctors, lack of nurses, pharmacology, or some other reasons. However, there are some other countries who have enough facility to take care of them. And it is not actually possible to communicate each other since healthcare has not been globalized yet. Would you be like to address this as well? How we can globalize healthcare? I'm not talking about medical tourism actually. I'm talking about affiliation, doctors being free to work in other countries, standardization, and a legal framework which will allow people to have the same rights when they get treatment in different jurisdictions and countries. Who should lead this regulatory system in worldwide? Should it be UN? Should it be WEF? Should it be WHO? Who should be the right organization?
Okay. Yes. Omar.
Actually, you tackled important topic. Thank you for that. But globalization of healthcare, in which terms? Can you go back to the microphone, please?
To enable healthcare to transfer from one country to another, or to be able to transfer the patient to another country, the legal system is preventive. Patients have some concerns regarding the liability issues when they get wrong treatment in that country. What will be the outcome of it? How can they sue their rights? And for treatment giving to another country, doctors are not allowed to work in other countries, in some other countries, I may say, without being certified in that country to enter into operations, or nurses to travel from other countries to give some services.
That makes sense, actually, because each country has its own standards.
Yeah.
Based on the laws and the policies inside that country.
That's what I'm saying. Can it be globalized? Can it be an isn't it possible to initiate an international standard as it is done in aviation business to globalize the system itself?
Okay, the international standard, let's go back to medicine. Medicine doesn't deal with logic. Medicine deals with facts. So facts are there in the textbook. So the treatment of, let's say, malaria, 1, 2, 3, 4, it's the same everywhere. The challenge is not putting those standards. As I said, the standards are here. Actually, we're here now in England. So we have the British School of Medicine and the American School of Medicine, you see. They're slightly different, both of them, but in the end, results-based or result-based medicine or evidence-based medicine, they reach to they will lead you to almost the same results. But let's say you have a person, a doctor coming from, I will mention a fake country, call it Marsh, coming from Marsh. What are the standards there? What did he study? You see, actually that person in Marsh, you can give him the same book, Bill and Love, Mengot, whatever, but is he able to do it? Can you implement it? Do you have the structure, the hospital, the facility to be able to deliver that? Does he have the equipment? Does he have the knowledge? And are there rules and regulations in that country which has guided him or guiding him? Actually, there is a lot of differences and disparities between countries. Who can do that? It's the leaders, the presidents, and actually the parliaments of each country. If all the parliaments decided that, let's say, for example, in England.
I agree, but we need one leader who will join the leaders of the other countries.
Say again?
We need another leader who will share that initiative with other countries' leaders.
Maybe other countries will disagree. Maybe you'll have a leader here who will say, fine, I'm accepting that a doctor from Marsh is going to come and treat British people. Maybe. But maybe the leader in Marsh will say, no, we're not going to treat the
Yeah,
British
it cannot happen today. I mean, we should first standardize the training education system to train the doctors, and when it is standardized, then the hospital system as well. But we need regulations in worldwide so that who accepts which country, I mean, whichever the country accepts that standards to implement in their own country, then there will be global system among them. And it will succeed, then it will be worldwide. It's just step by step, not right now.
Okay, well, thank you very much for that. I think you've made it clear what you're proposing. I think achieving that is some way away. Okay, we've just about run out of time. If you can be very quick, we can manage one question.
My name is Yousef from Washington, D.C. Just one comment on, preventative measures, as you know, as you mentioned, do work. The Framingham study in the States, simple measures, you don't have to spend a lot of money, not fancy diagnostics, has clearly resulted in a downward trend in cardiovascular diseases. The other, not meaning to be flippant, but I think what we do by managing chronic diseases better is that you delay their onset. So instead of having it occurring at 40, you're going to be operating on the same guys when they're 70. So I think you've got to have both prevention and you've got to be prepared to sort of deal with older people with the same disease states.
Okay, thank you very much. That's very well made. Well, I'm afraid that we have run out of time, but I'd like to thank you all for the contributions that you've made. I think it's been an excellent discussion. I'd like to particularly thank our panel members, and I wonder if you could just show your appreciation in the usual way. Thank you very much. And so we now close the session. Thank you.